Thank you very much for all you brave souls that were up here. And now I understand why I was told just to say, because Philip likes to have fun, which was why that was happening. So thank you. And Emily, not much time here, but asking you to put on a different hat so you can regroup and lead this next conversation on intentionally designed health systems for kids. Thank you.
We're just commenting on the fashion coordination of this panel, so the bar has been raised. That's it. Okay, welcome to our 12:30 session, where we're going to be focused on high-performing health systems. We talk a lot about integrated, innovative, accessible, equitable health systems for children and youth at Children's Healthcare Canada in the context of our vision and when we're thinking about right-sizing healthcare for children and youth. So thrilled to dive into this conversation today. This week, we've discussed government policies that affect children and families, the role of accreditation and standards improving the quality of healthcare services for children, leadership of our healthcare systems, philanthropy, and the promise of learning health systems and data to improve outcomes and care for kids. This afternoon, we're going to discuss how we use all of this information and knowledge to intentionally design health systems to fit the unique needs of children and their families. I'm here today with three friends and three remarkable women and leaders who are going to bring their experiences working with health systems designed specifically to improve experiences of care for kids. Immediately on my left, your right, is Lauren Ettin, who is the president and CEO of the Pediatric Oncology Group of Ontario, commonly known as POGO. To Lauren's left is Jennifer Proulx, the Vice President of Child Development and Community Services at CHEO. And far left for me is Jennifer Scarr, the Executive Director at Child Health BC. These women are all remarkable leaders, as I've already mentioned. I encourage you to look up their full biographies on our website. So ladies, let's get started. Can each of you take a couple moments to briefly introduce the work that you're leading, the audience your services are focused on, and how the work you do takes a systems approach?
What are you laughing?
Something fell over there.
I'm happy to start. It is wonderful to be here today. This is such a great topic because I think for all of us, it's been a good conversation and some reflection about where our programs and organizations have been and where they're going, and looking forward to hearing from the two of you as well. So as Emily said, I am the CEO of POGO, which is the Pediatric Oncology Group of Ontario. So we're the organization that actually leads and manages Ontario's childhood cancer system, which is done so separately and independent from the adult cancer system. And I think one of the greatest things about this organization, I've been here almost a year now, is that it actually is a true capital S system of care. That we've actually built something that puts children and families at the center, and that we support children and families where they are in their journey, whether that's from diagnosis to treatment to survivorship or even end of life. And that when we talk about putting children and families at the center of care, we're not only thinking and looking at that from their health perspective, but from mental health, psychosocial, where we know that when families get a childhood cancer diagnosis, that they almost immediately have financial toxicity. So we have a financial assistance program. We know that children who are getting their services and getting their programming at tertiary centers really want to be going back home, and they want to be with their family and their friends and back into those rhythms of daily life. And so we built a system that has care at the 5 tertiary centers across the province, but also at 8 community hospitals across the province, so that really when and where it's appropriate, families can be getting care closer to home, and they can be supported with those networks and those communities that they need in order to thrive. And so really when we think about building an intentionally built system, it really truly is looking at a family and all the aspects of what a family is and how we can best support them through their journey, no matter where they are, and then all the way into adulthood as well. So our system, while we deliver care to children, we actually have a significant survivorship program. 85% of kids who have cancer survive, which is incredible. And what that means is there's a burgeoning population of survivors. And so our childhood cancer system actually extends into the adult system so that they're screened all throughout their life.
Wonderful. Jen.
Hi, everybody. Jen Proulx. So I'm here to represent our incredible partners of the Kids Come First, Les Enfants Avant Tout Regional Health Network. And so CHEO serves as the host organization for our network. And for those of you who may not be familiar with the Ontario landscape quite as much, just a little bit of quick history here. So in 2019, the Ontario government announced the intention to move towards the establishment of Ontario health teams. And so these were defined geographies with attributed populations to serve the lifespan within those local communities. And we were in a really fantastic position within our region around child and youth health because just a couple of years prior to that, there was the release of something called the Thrive Report, which was the first ever sort of 10-year pediatric capacity plan looking out at what we thought we would need to support children and youth in our community. And so we had mobilized a lot of our partners to do that great work around Thrive. And so then in 2019, when the government put out the call for health teams, we knew we had the appetite and the desire to mobilize together to establish a health team for child and youth. And so we are one of I think an N of one in Ontario, where we are focused on children from birth through to that transition to adulthood. To date, we're over 70 partner organizations as part of our regional health network. We also have child, youth, family, and caregiver partners, physicians, and many other clinicians that come together to do some really incredible and groundbreaking work. We're funded through a variety of means, and we're going to talk a little bit about that over the course of the time together today. So both provincial funding, we have some federal grant funding, and as well philanthropy. So happy to dive into that. But we are turning 6 this year, so it seems right about the appropriate age when you talk about child and youth health. So turn it to Jen.
Thanks so much. So 2 Jens up here. So I'm Jennifer Scarr, and I'm the Executive Director for Child Health BC. Child Health BC was established back in 2006, and it was through BC Children's Hospital Foundation funding. And the reason why it was established to really recognize that there were 1 million children and youth across a vast geographic area, and really truly the healthcare system is predominantly adult focused, and so it was established to really focus on the children and youth population. More recently, probably in the last couple of years, we actually have evolved over that time, and now we are a health improvement network. And this is a new concept within British Columbia, where there are 7 of us as health improvement networks that really look at either population or like disease-based or site-based, such as emergency departments or critical care. And truly, as a health improvement network, we want to bring together all of our partners across the province who have a focus on the children and youth population. So for child and youth, it's our regional health authority partners. BC Children's Hospital is a key partner with us. We also have relevant ministries. So we have the Ministry of Health, obviously, but we also, because we're looking at the health and well-being of children and youth, we also have Ministry of Education and Childcare, and also Ministry of Children and Family Development. In addition to that, we have provincial organizations. And so some of the provincial organizations that also sit around on our partnership table are organizations such as Doctors of BC and BC Pediatric Society. And so the purpose of that is for all of us to work together to look at what we need to do to drive improvement in the health system to support the children and youth population.
Thanks so much. I had the chance to participate on one of those calls, and it is such a rich, diverse conversation when you have that breadth of colleagues in the room with you. So as I listened to each of you speak, and in our conversations leading into this panel, we spent a lot of time talking about the value of those partnerships and collaborations. And I'm wondering if you can talk a little bit about how do you effectively engage existing new partners in your bold, brave vision for where you want your systems to go? How do you encourage them to be part of this vision? How do you make them feel safe in the conversations that you're having and that they have a role to play? And anyone can answer. This need not go in any sort of order.
Okay, so I'll start. So one of the things, and it's a theme that we've heard here at this conference, is collaboration. Collaboration not only in that way, but also building those relationships. So the relationships are key to actually being able to move forward together. So the opportunity is to is to have the voices of all the partners at the table when you are looking at doing any kind of priority setting or developing any kind of resources or any kind of areas where you want to look at improvement. And that collaboration, that relationship. The other thing too is have fun together. You need to have some fun together, right? In order to really move the dial.
Love that.
I totally agree with those comments. And I would add that, sometimes those words of bold and brave can be really exciting to some people, and to others that can feel rather intimidating and feel a little bit less secure. So I think part of the important approach here is to understand where all of your partners are at in their own respective work. What is it that they're excited about? What is it that they're worried about? And in our case, or in our early days, was to be really clear about what the value add would be to join part of the Kids Come First network and what it wouldn't be. Right. So as an example, it wasn't to presuppose that we would be eliminating all of the independent boards of governance that those organizations had, or that this would impact their respective funding. It was more about how do we come together to create something new that helps to anchor us in our shared commitment to kids and to kids and youth. And so, we learned very quickly through the pandemic, because our sort of designation as a health team came at the end of 2019. And then just a couple of months later, the pandemic was here. And so there, as you all know, there was this agility that we needed to have to respond to the needs in the community. And so through our network, we were actually then able to deliver on function first rather than form, right? And so we were trying to deliver outcomes, not org charts. Like, let's get to the work of what we actually want to achieve together. And the faster we could do that and show some traction and show some impact actually led to feeling a true belief, oh yeah, we can do this together. And it kind of creates, I've said this in other conversations, it kind of creates that flywheel, right? That you end up having some impact, you can move it forward and do the next thing and do the next thing. And so that helps us now actually have a trust amongst our partners to go after those bold and brave ideas, because we've seen the success that we've had to date.
So I think I'd build on the concept of trust and collaboration and agility with where and when possible evidence. So we're in a really unique position that we're a prescribed entity in Ontario. There are only 4. And what that means is that we collect the personal health information of every child who receives a cancer diagnosis. And that means that we have data on that child from pre-diagnosis, diagnosis, their treatment, their survivorship, their outcomes, and that we can link that data to tax databases, to their mom, to their siblings, to their educational attainment. So we can really get a really great picture about what it means to receive a diagnosis and what care looks like across the province. And so that when we're working with our partners, when you think about having children with cancer across the province and really wanting to have having a critical mass in different geographies, really building that partnership through some trust and some transparency, because we actually have access to data and evidence and research of which everybody across the province might not be aware of. And so building those partnerships through collaboration and trust and supplementing with evidence and research where we possibly can, I think really helps build that shared goal and that shared vision of where you want the system to get to.
So you ladies will know that often in attendance at our conference are many family partners who care deeply about the work that we're leading together. I'm curious if you can talk a little bit about how family partners or youth themselves have been engaged in the development of the vision for the programs that you're leading and some of the priorities that you're pursuing.
When we were establishing our application to government, we were unnamed. And so we weren't the Kids Come First. We were to be named by kids, ... And we actually had a really great community engagement to hear from youth firsthand about what they thought we should be called. And so I remember him so well. His name was Remy, and he was a 6-year-old who, through his family doctor, put forward the name Kids Come First, Enfants Avant Tout, which was ultimately selected by the community. And I think that really set the stage for our commitment to partnering right from what we decided to call ourselves. And at every level of our health network structure, from our steering committee to our 7 working groups, we have either co-chairship of child, youth, or family partners at the table. We have many members of them at our working groups co-creating the work right alongside us. And one of the things that we're really proud of that we co-created with youth and family partners was our child, youth, and caregiver family compensation framework. And so we talk a lot about making sure that we are really working with child and youth family partners in an equal way, in an equitable way at the table. And so this compensation framework was one way for us to do that. And happy to share that with anybody who might be interested. It's been something we've shared broadly across Ontario for other Ontario health teams who are looking to do this work, and really does set the stage and the tone for how we want to support those voices at the table. But essentially everything that we do as a health team, right down to our branding, to our website content, to anything that we're producing, is done in co-creation with youth and family partners.
So I'll add, I didn't say this in my intro, but POGO is a not-for-profit and a charitable organization. And I know we'll talk a little bit more about philanthropy and build off of this morning's conversation and podcast. But when we talk about parents and families being partners, that's not only in the delivery of care and the care programs, but actually through our philanthropic arm as well. And how important it is to really center everything that we do when we're talking about supporters and donors and partners. And donors is actually being part of our partnership, not just what we kind of traditionally think about in the healthcare system, and really centering on patients and families. And our patient and family partners and our ambassadors, particularly through our charitable side, we could not do anything without them. They are the core reason why we're here. They are the core reason of what we do, why we do. And pretty much any forum I go to, I say 2 minutes and you let them have the rest of the space in place, because that's why we're here. And so I think sometimes when we think through a healthcare lens, we always think about them through our governance tables and our development, and we need to always think about them kind of more broadly as well.
So for us, well, we didn't have children and family help name us. What I can say is in any of the initiatives that we do or lead, they are always there at the table. And like you said, Jen, about the compensation framework, that's how it's evolved over the time. Is it's really recognizing the input and the insights and compensating accordingly. And I think that's the evolution that we found, and we will continue to evolve and think about other ways to continue to have parents and children and youth involved in any of our initiatives.
Yeah, we also did not have children name us. That's why we're the Pediatric Oncology Group of Ontario. My director of comms is in the audience today. Yeah, maybe we'll do that as round 2.0, 40 years later.
Yeah, we'll circle back on that.
Yeah.
Besides partnerships and collaborations, are there other ingredients to the secret sauce that's driving your success or underpinning your success?
I'll go first.
Yeah.
So I know the title of our session is Intentionally Created and Built Systems for Kids. And certainly there's a lot of intentionality, but I think also to balance with that is opportunism. So when POGO was created 40 years ago, there was certainly a group of visionary leaders who came together and thought, we know that we can do differently and we know that we can do better. And actually, POGO's origin story is that it was started by a pediatric oncologist and his wife, who was a psychiatrist. And they had a child who received a cancer diagnosis, and their child died. And they said that if they could not possibly move and maneuver through the system, then nobody else could. They could not be better placed to do so. And so I think with that comes opportunism. You see an unmet need, you bring together like-minded individuals, and you try to drive that forward. And that's definitely how we started. But I think that evolves then into intentionality. Once you have that speed and that rhythm behind you, then you focus on what your priorities are and you grow in breadth and depth. But I think what also comes with that is that visionary leadership. You need either a person or a group or an organization to be that collaborator, that convener, that communicator, to bring people together, like-minded people in like-minded organizations with some visionary leadership to move things ahead altogether.
So I'm actually reflecting on what you said about the secret sauce, and I'm going to change my answer of what I had in here, because I just went to the Ripple session. Anyone gone to the Ripple session? Resources for Interdisciplinary Pediatric Practice and Learning. Shout out. So I'm actually thinking the Child Health BC's secret sauce is the team. And we collaborate across the province, but what has happened over the last 10 years since I've been with Child Health BC is that team has evolved along with the evolution of the Health Improvement Network. And so when I started, like I said, 10 years ago, there were, I think, 7 or 8 of us, and now there's 34. And with that, though, we've actually been kind of intentional around making sure that we have team members from across the province. So they hold us, me as a leader, accountable for where they're coming from across the province too. So it's not just our partners that are holding us into account, but it's also the team members that I lead.
I love that. Jen?
Yeah, I would add to, so, as we think about children and youth and where we hope they're spending the majority of their time, which is at school, learning and growing and thriving, and in their communities and community spaces, and whether that's the community center, whether that's, playing a game of pickup ball on the court in their neighborhood, we really need to think, and I've been so encouraged throughout the last sort of day and a half to hear that we need to think beyond the healthcare system to support the well-being of children and youth. And so that cross-sector collaboration, and I think we could have a whole session just on how to do that well. Every province is structured differently in how that's done, but I truly can't speak enough to that. And in our case, there's even just been a couple of examples in the last 2 days where colleagues that I work with have said, hey, you know what, we're going to be doing something with paramedics. And so while that's still within the health system, that may not have been something on our radar, not that long ago. Or we have an opportunity maybe with one of our local colleges to help address a challenge that we're seeing. And so really is trying to think beyond the sector that you're from and move the needle that way.
So, Jen, that's a perfect segue. We spent yesterday morning, I'm not sure if you were with us, hearing from Andre Picard and a panel talking about political determinants of health. And we heard a lot about barriers in that conversation. But governments can also be important enablers of our work and of health outcomes for children and youth. So I'm curious how governments, whether it's federal, provincial, municipal, have supported or shaped the work that you lead. Do you consider them partners at your table, or do you consider them just as funders, or do they play other roles? Can you talk a little bit about that?
So I can start with that. So Child Health BC's action plan is developed in partnership with all of the provincial partners that I already described. And so there's Ministry of Health. And within Ministry of Health, there's several different areas within Ministry of Health. So there's population and public health, there's primary care, and then there's clinical resources. So we have reps from all 3 areas that sit at our table. We also have, I said, the Ministry of Children and Family Development and the Ministry of Education and Childcare. And really, truly, that's what makes it kind of challenging when you have these steering committee meetings, because you want to make sure that you're doing things that are relevant or having relevant conversations to everyone. And so it's been quite a journey trying to make sure that all voices are heard and they see themselves in our action plan. And so they are absolutely a partner in everything we do.
I would add to I think maybe in the initial days of how the government was thinking about Ontario health teams, they sort of laid a framework and some groundwork for how to do that, and really left it up to the healthcare providers and those organizations and those family partners, clinicians, to determine what were the priorities that they had and then to mobilize accordingly. And I think we've seen a bit of an evolution of that in Ontario, where there's been more direction provided through government and funding tied to that. At the same time, though, with our experience, we've seen many times where government has come to us and said, we really want to learn about how you did that. What made that successful? And so to me, that sort of shifts the conversation from it not just being a funding relationship, but actually trying to learn about what was working and is this something that could be scaled in other parts of the province? And so we are definitely welcoming and embracing those conversations about what have we experienced and how did we achieve success? And so that's been really fantastic to see. And I also think, we're starting to see these examples where ministries are wanting to come together to say, how do we work together to achieve an outcome? And so we've had this beautiful example of an extensive needs service. It's been a proof of concept with 3 partners, Holland Bloorview, McMaster, and CHEO, really defining Ministry of Health, Ministry of Children, Community and Social Services coming together to fund something that they know will have impact. And I think that's the beauty of where we need to get to, is more of that interministerial collaboration.
And I would add, I think we're in a bit of a unique position as being a not-for-profit. And so we're actually independent from government and yet the advisor to government. And I actually think the beauty in that relationship is that POGO has built credibility with government partners. And I think you're right. Government isn't a thing. Government is many, many, many things and many, many people. And building that credibility and building that relationship so that they can champion internally. Because you can do a lot from the outside, but you can do even more when you have those champions inside. And I think those champions being diverse, whether from the bureaucratic side and or the political side across multiple ministries, I think will always be of benefit to you in this system if you can have those internal voices there as well.
Great. This morning, earlier today, we had a conversation about, in the context of our podcast, about the enormous role that philanthropy plays supporting the delivery organization of children's health. How much of your core programming relies on the generosity of giving, philanthropy, etc.? You touched a little bit on it earlier, but hoping you can expand.
So 100%. I mean, our funding is not 100% philanthropic. We could not do what we do without our donors. And as we talk about partners, donors are our partners. They are invested in what we do and the programs that we deliver and the children and the families that we serve. And our charity is actually under our organization and under our arm. We are one organization. And what that means is that we have flexibility and nimbleness, that when we know there is an unmet need or when a child and a family are plural, identify an opportunity, we have really deep and broad donor relationships that help us act more nimbly. And that could be, in a proof of concept of getting something off the ground and then moving it over to government funding if that exists. We fund our research. A lot of our research is donor funded. But I think most importantly, what we have as donor funded are those programs and services which we would consider as wraparound. So certainly, we are in the healthcare system and we support through our hospital partnerships across the province. But we know that children and youth want to get back to their activities of daily life. And so for youth, that means getting back to school and work. And so we have a school and work program that helps kids with their resumes or their accommodations at school or their applications to post-secondary education, because these are kids who perhaps haven't had like a traditional school path or a traditional career path. And that is donor funded. We also have a financial assistance program. We know that when a child gets a diagnosis, in the vast majority of cases, one parent almost immediately stops working and a child will be in care for months and usually years. And so there's a lot of financial toxicity. And so we have a financial assistance program. We couldn't do any of that without our donors. And that is core to who we are and what we do in supporting our patients and families. And lastly, I would say by having a philanthropic arm and the support of donors, it means that we have a more diversified and sustainable funding base. It gives us flexibility. And I think from somebody who came from many organizations that didn't have that charitable arm as strong, the ethos and the approach to what you do and how you do it changes because it opens up a world of possibility and flexibility that you don't also always necessarily have with other funding sources.
So if you look at our logo, you can see that we were established as through the generosity of donors at BC Children's Hospital Foundation. And Save on Foods was a key benefactor, our lead benefactor. What it has provided us is to, as I said, establish the health improvement and network approach across British Columbia. And what that has led to is, I said at the beginning, we're one of 7 health improvement networks. So all the other health improvement networks are now funded with government funding. So I agree about the nimbleness and stuff and everything else that everyone said, but really, truly, it wasn't for the donors, then the other health improvement networks wouldn't be around. Mm-hmm. So in addition to that, it really helps to, as Lauren said, you can see opportunities. There's There's funding in order to really try some transformative models. And then through that work, then determine what you need in order to sustain it. And then you have that rationale that you can go to government and say, okay, this is what worked. This is how we're going to do it in order to sustain it.
Agree with the comments from my colleagues. And, I firmly believe sustainable care needs sustainable generosity. And so we are at CHEO and with Kids Come First, we are so privileged and grateful to partner with the CHEO Foundation in our efforts around this. And some of our most impactful programs to date as our health network really had started with thanks to philanthropy. So if we think about our One Call, One Click program, really was able to get off the ground because of that. And, I reflect on that actually because the philanthropy or the charitable giving, and Steve talked about that this morning and sort of this difference between the two. And I think that's really insightful. But those dollars can actually either help you to lift something significant, right, that you otherwise couldn't. It can also then be a bridge to your collective advocacy with your funders to help demonstrate the value of what you've done together and bridge to get to that, hopefully, base funding, year-over-year funding. And it also can be transformative. And so to me, that is absolutely a key piece to how we move forward. And, I think the other thing that we reflect on is that it doesn't just have to be transformative. If you think about the operational needs that we all have within our organizations that touch so many children, that's pretty profound. Like that's something we can get donors behind as well. And so it's not just the big transformative pieces, it's the actual breadth and reach that we have. And through our network of over 70 partners, you can imagine that that's quite extensive. And so, really such great value for us as a network to be able to tap into that support and partnership.
Recognizing that often the specialized pediatric care that our kids need is located in urban centers, what are each of your programs doing to build equity and access in communities that aren't downtown Toronto, downtown Ottawa, downtown Vancouver? How are you ensuring that as many children, youth, and families as possible in your respective jurisdictions are able to take advantage of your services?
So there's a couple of examples. I mean, I think I'll talk about a couple of things. Again, Ripple is a great example again of increasing access across the province. Using a tool that folks can access in all areas across the province, I think is an important one. And so really low barrier as much as possible. The other thing is we are actually really moving towards being data informed in everything that we do. And in that aspect, we are able to now identify unwarranted variations across the province and be able to have conversations with partners around these are unwarranted variations. What can we do together in order to address them? And so rather than an entire provincial approach, it might be that you work together with one or two areas in order to help lift them all up. So that's how I get to that one.
Thank you.
So our geography is pretty vast, and it does span both kind of those urban and more rural communities. And so we've been very intentional around how we've structured ourselves. I talked earlier about prioritizing function over form, maybe in your early days to get that traction. But then as you mature, you do need to have the supportive form behind that and the structure with which you're going to work together. And so we've been very intentional. We have members at our steering committee that represent some of those different rural communities and organizations to make sure that we aren't just solely focused on Ottawa, let's say, and that we're thinking about our eastern townships or our western counties. So, making sure there's seats at the table to hear from those leaders and to hear from their teams. So that's one thing we've done in terms of our structure. And then we've been thinking about, well, we know that we want to be able to deliver care closer to home and make that a good experience for kids and families as part of our network. And so we've identified opportunities like our regional surgical pediatric program, where we can bring expertise from the Kids Come First host organization of CHEO into those community hospitals and work with their clinicians to say, how can we identify some procedures that we can help build your skill and capacity for so that those kids can receive their surgery closer to home and families don't have to travel all the way into CHEO. And so we've onboarded a number of hospitals already and, meeting with their senior leaders to identify what's working. That work is spearheaded by one of the CEOs of our community hospital partners. And so really feeling led and a shared accountability around how to shape that work has been really successful for the team.
Yeah, that's been a real win-win-win, I think. Yeah. Lauren.
I would say that is the core model of what we've built in the province. So there are 5 specialized children's cancer programs in the province, and they're all in the major cities. And recognizing that children with cancer often have services for months, and actually quite often for years, they're in active treatment, and just the impact that can have on a child and their family, continually driving hour after hour to get chemo or radiation or the other services they're getting. So what we've done is we've built actually a network of satellites, and though those satellites are 8 community hospitals across the province and local communities where there's a critical mass, and we know we have a critical mass because we have the data, and really forming true care teams that are tertiary community hospital care teams, and with a recognition that each player in the system has a role to play, and there will always be a role for a tertiary center in a child's care, and there will be a role where and if possible and probable for a community hospital to play, and that we really build I think similar theme there around building capacity of teams across the province, whether that be through partnerships or learning or education, et cetera. But really for children and families, they love going to their community hospitals. If you ask them, that's where they want to go. They don't want to be driving down to a major city at 3:00 in the morning when their kid has a fever. They want to go to the care team who knows them inside and out and is actually a part of their family. That is how they describe them. And so that's really kind of been embedded in what we've done. And then we've grown it to say, well, if that works for active treatment, and then what do we do for survivors and aftercare? So what do we do for the 85% of kids who survive? And we know the vast majority of them are going to have lifelong health impacts. What do we do for them? Well, we do something similar. We have aftercare clinics, again, across the province that screen children and adults who are survivors of childhood cancer. So again, they don't have to be coming. We need to make it accessible. We say close to home, but close to home also means accessible. It also means making it in a way that works for children and families, not that works for the health system. And so it's building a system of care for survivors as well across the province.
Love that. Just before lunch, we heard a really phenomenal panel discussion on AI and precision health, and some flavors of learning health systems and the role that is playing transforming healthcare. So if we think about the programs and systems that you're running, are there dimensions of AI or future-oriented technologies that are supporting families, is supporting your work, helping with prediction, modeling, otherwise?
So I'm smiling because, well, that session was just, I could have listened to them all day. I don't know about you. And for people who know me and work with me, I am by no means an expert in those areas, but my goodness, I have such an affinity for it. I want to learn about it. I just think it's fascinating. And so, Dr. Kathy Pager spoke about the opportunity with Precision Child and Youth Mental Health to think about how do we bring that to our Kids Come First regional network partners. And so I'm really, really excited to see what the opportunity might be to introduce that to our partners and how we can work together to identify, both from a data collection standpoint to help understand the population of children and youth that we're serving, and how does that inform care going forward. And so I think we have more to do around bringing that to bear on our health network. I do really feel, though, that the opportunities that affords us around following a child through their developmental journey and their health journey and their trajectory is really going to be something to watch. And I know that we have to be mindful, as others had posed in the question period, just around making sure we have the best and the right data and that it's inclusive and we're understanding the impact of some of those, fundamental needs that children and youth have. Ultimately, though, these concepts of, I think John spoke about it, but this digital twinning concept, I mean, how fantastic to think that you could look at a child's journey through their age and development and have a digital twin with which you could say, gosh, if we offered this, would this impact their well-being and their outcome and their trajectory? If we did this instead, what would that mean? And to be able to do that at a scale of hundreds of thousands of tens of thousands of children, it's just really exciting for me to even think about what that could look like. And so, I'm all in. So if anyone here wants to do something like that, wants to think about how to bring that to bear, please come and chat with me, and I'll connect you with the people that know more about it than I do. But I truly, truly think that is going to be phenomenal to watch. I'm excited to see it unfold.
Really exciting.
Yes.
I'm going to go hang out with John Jacob when I get back. Let me tell you, he's got lots to teach me. Now, the other thing too, I just want to, the other questions that came up, thinking about it across a large geographic area. And in BC, much like many of the provinces across and territories, that northern part of our province, Northern Health Authority has 2/3 of the province, the geographic area within British Columbia. And so it's a vast geographic area, and cell internet service is not available across that large geographic area. And if you actually look at population data, you got to really think about how to support those populations that are in most need. And how do you get to those populations in a way that is respectful and demonstrates that you're trying things for that population too, and not just for the ones living in the Lower Mainland.
Did you want to expand on yes or no?
Yeah. Well, I think one of the things that I feel like every week I learn something surprising that makes me smile. And one of the things that I didn't appreciate was that in cancer care, clinical trials are the standard of care. And so what that means is that new drugs and technologies are right at the forefront of care all the time. And yet there's still that challenge around ongoing and sustainable funding and uptake and implementation. But I think the opportunity that we have in pediatrics broadly, and certainly within the cancer system, is that equity of access is not only provincial, but national. So all the work that's happening on the child health strategy around what does equity of access look like nationally, I think is even more important when it comes to drugs and technology and precision child health, because there will likely be leaders in some areas of the province and or country who can then use that momentum for the rest. And I think that's our imperative as a community and as a team.
That's a perfect segue to my next question, but I will give our audience a heads up. I have 2 more questions, and then I'm going to turn it over to you. So give some thought, and please make your way to the podium if you have questions for this incredible panel. So Lauren, I want to pick up where you just left off. So as you know, Children's Healthcare Canada is on a mission to help right-size health systems serving children and youth, improving access to equitable, high-quality care for children and youth, no matter where they live in this country. I'm curious if you have any lessons learned from us, any sort of tangible advice that you would give Children's Healthcare Canada as we begin to shape messaging and priorities in this regard. Anything you can share, any wisdom you can impart with my team?
So I'm going to share something that Rita isn't here this week, but she's our Quality Improvement and Evaluation Director. And she coined this term, telling a provincial and a local story, and we could say national, to improve care and outcomes through data sharing and reporting in an environment of trust and learning. And I think that encapsulates it quite nicely. We got to build on all of that. We have to have data available that we trust, that we're not going to use the data for anything untoward, that is actually to support quality improvement. It took us in BC, again, I'll shout out to Rita. She spent 2 years working diligently, and she has now got a data sharing agreement and information sharing plan with all 5 regional health authorities. And that takes a long time to do. So the sooner we get to that, being able to really have those conversations using the data to support the conversations, the better we're all going to be.
So I think one thing that is a lesson learned, but an opportunity for all of us in our roles as leaders and those that we work with who are influencing policy, creating policy, really is that it is possible to align missions across ministries, across provinces without having to merge your mandates, right? And so how do we do that in a way that allows us more flexibility with our funding? And so today, we've heard about philanthropy. We've heard about unrestricted funds and the importance that can bring to bear on actually delivering new and innovative work. And so, this concept of advocating and asking around braided funding models as an example. Like, why can't we be pulling together funding from different ministries to achieve a set of, as Jen said, shared outcomes? We can still trace that back and show accountability for that funding, but how are we actually bringing it together, weaving it together in a way that helps us move forward together? I would love to see more of that. And I think when we talk about kids, it has to extend beyond health funding. We have to think about how do we pull together our partners in education and what of the education funding can be married with health funding, could be married with, if it's a Ministry of Children and Community and Social Services, how do we bring that money together with philanthropy in a way that really gets us to right size the system? So that would be a piece I'd love to see.
Thank you.
I think probably what I would add is perseverance, which is what you do and what you do so well. I think often we hear that in general, children are healthy, and we are here to certainly help those and to help those who are not. And that perhaps we don't always have a critical mass at our local or regional or provincial level, but we certainly do have one at a national level. And when we can, what's that saying? When you rise, I should not try to say something that I don't know what it is. Rise the tides will raise all boats, or that thing where we know that when our children are better off, we are all better off. But we also know that when things happen nationally, regionally, locally, or provincially, we are also all better off. So I'd say I'd continue to advocate for your team to continue to advocate on behalf of all of us and know that we can achieve more through partnership and through working together to raise voices across all, and we can achieve more together.
I love that. Before I turn over to audience questions, I guess my last question is there anything you wanted to tell our audience today about our programs that we didn't talk about specifically? There's so much great work happening, and I know each of you have particular passions related to your work. Is there anything else you wanted to share about your programs?
I would just say, I think one of the things that the most important thing that I hear from the patients and families that we support is that the end of cancer treatment is the start of the cancer journey. And that's been a really, really big learning for me, because what it means is that we really wrap our arms around children and families. And I think this is probably not unique to cancer, when they're actually in treatment. But knowing that kids in any capacity who've gotten treatment, when that treatment actively finishes and you ring the bell, that's when you hear from the parents and the caregivers. They say, you know what, I've been working on adrenaline for years. Now I've dropped. And similar to that transition from working from a children's system to an adult system, that's when they lose their care team. That's when they lose their supports that have been around them for years and years on end. And so that when we think really what we mean about wraparound services, we should really be thinking broadly what we mean around wraparound services, and not only during those active, really challenging high treatment times, but what are those lasting impacts? What are the mental health impacts? What are the impacts not only then on the child, and the caregivers, but the siblings? We hear a lot from siblings about the need for support for them on an ongoing basis as well. And so I think as we talked about child and family centered care, extending what that family is that's within that family construct, and the time period at which we support them, and really making it a much longer, more encompassing time that we provide support.
So I haven't spoken so much about it, but it is such an essential part of everything that we do in Child Health BC is recognizing our commitment to truth and reconciliation. And that has been, we talk about this as a team, is we've been on a journey and we continue to be on that journey, but it is a fantastic journey. And to see the team embrace that and build that into everything that we do has been tremendous.
So I would reflect that, coming to these conferences is inspiring because we feel sometimes, right, that today's system has really been designed for yesterday's kids, right? And kids these days need something really different. And so what you all are doing and the innovation and the creativity with which you're bringing to bear and the partnership, the true partnership, to me, we just have to keep moving that forward. I think nurture, I can't underscore it enough how important it is to nurture the relationships so that you can have the trust to really build quickly or build differently to create, more of the partnership and more of the bold ideas. So it's really around nurturing that to help us achieve what we want and what we know kids and families need.
I just wrote that down, Jen. Today's systems were designed for yesterday's kids. Such a poignant statement. I tell you, the CHEO team is really good at these one-liners. Everything I've heard you say reminds me of something Megan said this morning about that idea of just a warm hug for kids. The systems that you have created in your regions, in your provinces for a particular population really are that warm hug, not only for the kids, but also for the family. Such important and incredible work that you're leading. Such an inspiring conversation today. I'm going to turn it over to the panel, to the audience. Sorry. Are there any questions that you would like to ask Lauren, Jen, or Jen?
Hi, good afternoon. I think my question lies at an intersection of a couple of through lines in both your conversation and what I've been hearing at the conference over the past 3 days. And that's the sustaining and building partnerships and connecting evidence and practice. And for context, I'm with ChildBright. We're a brain-based disability research network. We've been studying implementation of our interventions. We've been having some success at smaller scales, I would say. And the question is how to then do this sustainably at scale and at that systems level. And everyone on stage here, I feel, are very well positioned to speak to the ways, hopefully, that you're doing this and you've seen it work well, connecting that research piece, that data piece into practice and maybe policy also. And maybe if there are ways that have not worked so well, because we can also learn from failures. And so I'd appreciate any insights you have on that level. Thank you.
Who wants to take that one?
So I can go. Jen S. is over here. So with that one, I was just going to, and it's this we were just talking about. It just got out of my mind right now what I was going to say. But no, now it came back. So when I was talking about the health improvement networks and that we're one of 7. So I think what I'd like to say is you continue to identify new partners in order to support you in the actions that you need to take. So, for example, there's a health improvement network called Critical Care BC. Well, we've been working with BC Children's Hospital, Critical Care BC, and Child Health BC to really look at pediatric critical care, because the Critical Care BC has those critical care partners within the health authorities. We have the pediatric partners. So together, we're better looking at critical care. Emergency Care BC, same example. So as you recognize the need to partner, just reach out and partner and build those relationships.
Thanks very much for your question. So Jen P. Sometimes and I think it was yesterday, somebody said, Canada's known as like the land of the pilot or something like that, that pilot study, pilot project. And so there's value in starting small, right? And then trying to figure out about how to scale that. Sometimes, though, there's real big impact when you start bigger. And if you know that the partners you're working with, your families, your patients, your community partners, whoever they might be, if you know that there's one of those big issues that has to be resolved, or it's been going on for too long, and you've got the momentum or the energy or the will to address it, I wouldn't shy away from stepping into that bigger piece to resolve. Like if I think about, and I know my colleagues are in the room representing Kids Come First, but if I think about One Call, One Click and the amount of co-creation and partnership that went into establishing that, every single community-based mental health provider in our region, family and youth at the table, co-creating it, clinicians at the table, senior leaders from these organizations. It was at a time where we knew, and someone spoke about this earlier during COVID, when the rates of kids and youth presenting for healthcare around mental health was significant. And so it was the burning platform to say, well, what are we going to do about this? And so it was big in its scope, but in fact, it actually, because people were committed to it, it resulted in huge change. And so then that's really been, I think, the fuel for us to be able to say, okay, what else can we do? Because that was a big thing and we were able to do it well. So starting small can work, but sometimes I would say don't be afraid to go bigger.
And I would say when you think about spread and scale, the great thing about spread and scale is that we know that we have a system wherever we are with people who want to do more and they want to do better. And sometimes you just need to make it easier. And the way to do that is if you have something that is a proven intervention and you have the tools and the resources and they don't have to create that can just be the nudge or the leverage or the way in to say, we're here to help you. We're here to support you. We recognize, of course, there's always going to be local context and local variation. But I think going into something new and thinking, oh my gosh, this is such a big lift. Of course I want to do it, but how and where do I start? And do I have the capacity and resources? And to have somebody come to you and say, we've got this really great proven intervention that we've done. This is how we did it. This is how we know it's worked. We'd love to partner with you. We'd love to learn together with you. And you're not alone. I think that goes a big way in developing those trusted partnerships and really fueling that spread and scale that, to the point of being a country of pilots or a country of one-offs. Really, it's that spread and scale mentality. And I'd say the flip side is approach a new implementation with the spread and scale mentality. It's more efficient to be doing things multiple times than to be doing them as one-offs. And so if you have that spread and scale vision right from the get-go, you probably will build in a different way than if you were just building for one organization or one project or one program.
Thank you. And I might just add to, I was talking to somebody at the lunch break around this, and in healthcare, I'm sure as there is in other sectors, sometimes we're struggling with the same challenge, right? Like, probably many of you have been working in healthcare for many years. And sometimes we hear the same thing and it's like, we haven't cracked that nut yet. And so sometimes I reflect on who are we missing at the table, right? Is there someone with, from another sector that we should be inviting to the table, to the conversation, because maybe they thought of something that's worked in their sector that we could be bringing into ours. And sometimes I just don't know if we're able to identify who's missing, but look outside of health to say, well, where have they had great success and who can we bring in to help shape the work?
Wonderful. We have time for one more question if there is one. I see a tough question coming. Ladies, buckle up.
No, not a tough question at all. It's been a fantastic, really, really fantastic panel. Thank you so much. I wonder, and each of you have drawn out so clearly how successful you've been in your systems. But everyone in this room has experience with systems that don't work very well or things that have tried and failed. And I wonder if each one of you could reflect on the one or two things perhaps that you look at as real success factors. It might be something about your unique geography. It might be something about the timing of when you started. It would be really great to get a tidbit or two that this is the thing that really made a difference and that may spark some other conversations.
So I will say that our history is so embedded in 2 or 3 individuals that when I say visionary leader, I mean capital V, capital L, visionary leader. And these are 2 or 3 individuals who had I feel like this is a movie, like a dream and a vision. It was not a movie, a dream and a vision, and really just that, really that perseverance, knowing that what they knew needed to happen, they knew it could happen, and I think appreciated that it was a complex undertaking to build a new system of care for kids with cancer, but they knew it needed to be done, and that knowing that it needed to be done just kept driving and driving and driving them. And this is 40 years ago, and I still hear about them every day in our hallways. I know them. I know them clearly, but I know them. I hear their names. That they are the, what's a good ghost? A fairy? They are the people that our team and our partners live and breathe and espouse their vision and their passion, and you can feel it every day. So I really think sometimes I think it comes down to just having that face and that person of those people who really are willing to do anything possible to make something happen and not take no for an answer.
So I'm just gonna challenge a little bit. There's success that we have had with Child Health BC, but there's still way more growth and development that we need to do in order to continue on with that. So, again, like I said, the commitment to truth and reconciliation is a journey. I think this whole health improvement network is a journey too. As I said, we started off 10 years ago with 7 of us. There's 35. Those positions evolve as the needs of our partners, as partners identify what we need to do to support them in caring for children and youth. And so to be open to evolve along with the needs of the partners, I think is the important and a really key thing.
So my feedback on this one might seem a little unusual, and just bear with me. I'll be quick about my answer. But so when the call for Ontario Health Teams was made, and I remember it well because I had just joined CHEO as the host organization, I think a week prior. And so it was April of 2019. And then submissions were due in May. And then if you sort of pass that first step in the application process, then a much more detailed application was required by October, so May to October. And at that point, we were maybe 50 plus organizations that were coming together. Reason I share that is that really firm and tight time frame was extremely helpful to us. Now, I know my colleague Sarah Bissix is in the room, and Sarah and I would have spent lots of long evenings trying to get that document tidied up and formatted. But the tight timeline, and that's maybe not realistic to fabricate or implement in the work that you're doing, but it actually really did help to make that a priority for everybody coming together to say, we've got to do this and we have to do this by this time. Fast forward, so that's a short amount of time. Fast forward to February when the pandemic hit, and it was like, okay, we just spent 6, 7, 8 months together in earnest working towards achieving this. Now we have to respond to the needs of kids in our community. And we were like, okay, we're going to go, because we had just spent an intense period of time coming together to figure it out. And so I don't know how you replicate that, because everybody's really busy in the work that they do, but there's something to be said for that close, the prioritization of the work in a tight timeline to help you move forward and form together quickly.
Unbelievable. We've got 9 seconds left. That was such a terrific and inspiring discussion, leaving us with lots of hope and lots of really practical ideas that we can take home with us today. So thank you so much, ladies, and thank you for the great questions.
Thank you. I also want to say thank you to Emily Gruenwoldt, Lauren Ettin, Jennifer Proulx, and Jennifer Scarr. This last hour, for me, there were so many ideas and so much wisdom. And it really continued on along the vein of what we've been hearing about in terms of collaboration and partnership. But the word that I was thinking with this one was integration. So sort of moving past that partnership in some ways, the integration of child, youth, and family partners every single day, in funding partners at the table, and integrating goals across ministries.